Our breakout session on caregiving of the aging LGBT community. So first of all, I would like to thank our sponsors, Dr. Marjorie Everson, CRNA, Tanya Carter, CRNA, Kind Companions, Educare, and A Place for Mom. They sponsored our session, and also I want to introduce our panelists. First of all, we have Dr. Brady Allen, MD, and HIV specialist. Ms. Vivian Armstrong, registered nurse and LGBT activist. And last but not least, Mr. Vic Holmes, who is representing the Coalition for Aging's Collin and Denton County Organizing Committee, as well as professor at UNT's Health and Science Center in Fort Worth. So we're pretty loose for this topic, but we're going to start with Dr. Allen. How can clinicians begin to address the healthcare need of the LGBT patient?
Well, part of the problem is we have to have more clinicians. You know, it's access, right? And I mean, we have a large gay and lesbian practice. There are eight providers in uptown Dallas. But, you know, several of our providers have died of AIDS over the years. Look how gray I am. There's several of us that will be retiring shortly. How to replace the providers for the LGBT community unless they're straight and educated and want to take care of the community, which doesn't happen. Part of the problem is also primary care. No one wants to go into primary care these days. You don't make enough money. You come out with $2,000 of debt and you make $150,000 a year. Not that that's chump change, but you know, you much rather be a dermatologist and make $250,000 a year, right? So part of the problem is the primary care squeeze, and that involves lesbian and gay clients. And now that we don't have the sort of tragedy of AIDS, there's not as many gay and lesbian individuals that want to go into taking care of our own community in medical school. Mm-hmm. So I think you're going to see this all of it sort of shrink, and that's part of the problem is access. I think the second thing is that you need to self-identify to your doctor, whether you're going to a straight or a gay doctor, because doctors are woefully inadequate, including some of the gay doctors, in trying to talk about your sexuality. And so if you don't self-identify to them, they are not going to, they're not going to treat you like you need to be treated. They might not be looking for the things that I tend to look for in gay and lesbian health. I think we also need to recruit paraprofessionals, nurse practitioners, physician's assistants. We need to go in the medical schools. Fortunately, Southwestern has invited us a couple of years in a row now to go address the medical students about gay and lesbian issues. That's woefully inadequate, but at least it's a beginning so that we can get people interested in what we do. And then advertise your expertise. I mean, you know, we had a transgender conference right before this, and the transgenders don't know where to go sometimes. Well, we have 3 specialists in transgender healthcare within our own practice. Now it's a private practice. What about where the indigent transgenders go? It's a different story. And is Parkland or Peabody or other places meeting those needs through expertise in that? So I really can't comment on the public sector health.
That's very true, which leads me to a question that I have for you, Vic. From your perspective, as not only a member of the LGBT community, but you're also a healthcare clinician. So what do you think are some of the top issues in our community's healthcare needs that need to be addressed here in North Texas?
I think the biggest need tags right off of self-identifying. We have two sides of this. We have providers, and we just don't have enough of them. That is true. But we also have patients who don't know what their needs are. And on the board behind me, I wrote, do you know what your medical needs are? As an LGBT member yourself, do you know what to look for when you're going to the physician? So I think that there's a deficit there in trying to identify our own needs. This is what I'm looking for, rather than just walking into the office and saying, you know, do whatever you're supposed to do. There's some element of that, But that element starts with knowing that, hey, I'm supposed to be getting this kind of test or this kind of exam. It's this time of the year for this. You have to know what your health needs are as well.
Vivian, we had a discussion where we were talking about what makes us comfortable when we go to a doctor's office or a nurse practitioner. So what are some of the things that a clinician could do to make their environment more welcome and more warming to us?
Some of the things are advertising in The Voice and in other venues on Lambda Weekly or what have you, so that people know that your practice is welcoming. Secondly, there's the national HRC Human Rights Campaign has the Health Quality Index. Unfortunately, we need more providers to in healthcare systems to participate in those surveys, because only Parkland and the VA are listed as participants right now and meet those qualifications. And if some of the other big health systems did that, that would encourage their physicians and all their other services to also end up becoming more welcoming, because you've got to have, meet that. And HRC actually helps entities get that way. Having rainbow symbols in your office, having pictures of a wide variety of families and couples and stuff can send that, because when you see two same-sex couples pictured, that's going to tell you something. You don't have to just have nice art on the wall, I mean, they can, decorate it, otherwise, and it carries a specific message. Word of mouth, knowing people who go to somebody where they feel they're getting good care, and that really helps. Follow your neighbor's recommendations sometimes, your friends who are going to someone, and call their office and talk to them. You can just call up and ask, hey, are you comfortable seeing somebody, who is LGBT? I have these kinds of medical problems, and this is my sexual orientation or my gender status, and this is the care that I need. Can your office provide that? Back in the day, Louise and I used to call the Vice Squad in order to be able to find where the gay bars are, and it worked just fine. So you can call the doctor's office. You can call the doctor's office and find out, at least if they're willing to answer your question and they say, I'm sorry, I can't help you, and hang up, then you know.
Okay, now, this is a question for all three of you, and we're going to deviate just a little bit from the way the other sessions are going, because I'd really like to get some feedback from each one of you, or maybe not each one of you, but just some feedback. What are some of the specific health concerns of not only the aging LGBT population, but of the LGBT population in general? And
Well,
we can start with our panelists here.
There's no such thing as a gay heart attack, right? I mean, there's no difference in lesbian and gay health care in the aging population. There are increased instances of STDs, so I think we'd have to be a little more vigilant. Yeah, old people have sex, right? And HIV care is, you need to test and treat immediately, for example. So there are a few specifics, but I think the bottom line, which we've talked about through the whole conference, is what are the end-of-life issues? They're more psychosocial issues that I think older gay and lesbians are worried about, rather than their individual heart or blood pressure. We treat that the same. But, stuff like, watch out for discrimination and stigma in long care facilities, right? What are we going to do at the end of life? Long-term toxicities of HIV meds are a little bit of a concern as we stay on these wonderful meds we have now. How are they going to affect you? We think HIV causes premature aging, so we have to look for that. And are there ways to? And a lot of people are working on this topic of how HIV shortens telomere length and causes early death, maybe 5 years less life expectancy only, which is amazing, right? These people are treated and undetectable with a normal T cell count. Why are they still dying 5 years too early? And we're trying to figure some of that out. Depression, isolation, loneliness is so increased suicide. So I'm more worried about the psychosocial issues rather than necessarily your medical health care, because I think that's the same. I'm going to put you on the same blood pressure medication as my straight friends, so.
So with a gay heart attack, use a rainbow defibrillator.
Yes.
I was going to say, I think social isolation is twice as bad for gay and lesbian people, and even for gay and lesbian caregivers like myself. And I pointed out is that I often used to give this to my patients, Celebration Magazine, for gay seniors in Collin County. And there are dances at all the senior centers, every single senior center and activities. But you never even hear a mention of gay or lesbian rights.
Yep.
So if you're a gay or lesbian person in Collin County, there is no mention of your existence.
Yeah. Yes.
Talk about HIV in lesbians, because I know a lot of lesbians do not believe that they can become HIV positive.
Oh, true.
Yeah.
That needs to be discussed.
Okay.
You still are sleeping with the people that slept before you, you know. So, you know, it's there. And lesbians are not necessarily all monogamous or even, you know, with just same-sex partners. So, you know, the potential is there. And if they haven't been tested, you know, hepatitis C is another biggie out there. And all of those tests, you have to realize, you hit Medicare, Medicare has a wellness thing for you. They got a whole laundry list of all that stuff you ought to be tested for, your immunizations and all of that wellness stuff. And all your physicians should be working on that, and you should too. You can print the list off the computer and take it to your doctor's office.
Yes.
I guess to go along with what Angela was saying, it's the fact that even if you do go into the doctor's office, you don't have discussions with lesbians and talk about sexual health and well-being, because that's if you know the assumption is made because you are sleeping with another woman that diseases aren't spread. So you have a lot of doctors who are not having those conversations with their patients.
Right.
I would actually like to say something there, because that is true. I totally agree with you, and to fix that, one of the things that we're doing, at least with UNTHSC, we have an LGBT panel every year where we have members of the LGBT community come and specifically address the medical concerns of our community with the physicians, the PAs, the pharmacists, public health folks, all the students that we have at the campus. So we have an open panel for them to come and discuss these things. And the first year was we required attendance because we didn't think we were going to get anybody in there. This past year, as the third year and fourth year for it, we filled the room. It was a 200-person room, and we didn't have to require attendance. So folks are wanting to learn about these things, especially now that they can. And that's how we're trying to address some of these inequities, because it's not just lesbians who sleep with the lesbians who slept with someone way, way long past. There are drug issues. Sometimes there's, especially in our community, there's a higher use of drugs, and intravenous drugs fall right into those categories. So you don't necessarily have to sleep with someone to get a disease from someone. And so to try and address those concerns, that's specifically what we're doing. This next spring, Dr. Michael Jan and I are making an LGBT track specifically for the pharmacy school for that whole semester. It's going to be just basically our issues, just pummeled over and over again. But it's a series of panels that the entire school is actually welcome to come and join.
But you have to advocate for yourself.
Yes.
Nobody else is going to do it but you. And that is so very important, is that you've got to be the one to self-identify. And that's the only reason that people were getting good HIV care back in the beginning, is they partnered with their doctors to get good care and encouraged them and worked with them. And you have to find physicians and you have to partner with them in order to be able to say, you know, I had a partner who had a drug problem, you know, or I did that back when.
You know, I'm surprised UT Southwestern Health Center is not part of the HRCF export listing. The Portland Gay and Gray Conference this year had a wonderful workshop. Lesbian sex over 70. And it was actually about lesbian sex and intimacy over 70. Now that is a workshop that there was genuine interest in and that needed to be discussed. Because as we're aging, I'm not ready to turn off the light. I'm looking forward to enjoy this life. Right? And so, and sometimes we have to be just as, when we're adolescents, as teenagers, we have to learn now about those things at this point in our lives.
UT Southwestern has, so I don't know what programs they have in their curricula, but in March, they hosted the Out for Health Conference, specifically at UT Southwestern. Last year was in Houston. It's a conference sponsored by the UT system. I'm the faculty advisor for the LGBT and Allies group at UNTHSC. And we send our students there. I go with them. It's specifically for healthcare providers to do exactly that. And one of the sessions they had this year, two of the sessions they had this year, was specifically about talking about sex with your patients. And yeah, people have sex, so these are some of the things that we need to look for. So I think part of what we're doing to address that is making people more comfortable with the topic by exposing them to it. Because if we don't talk about it, you're never going to think about it. And if it's something that you never think about, you're not even going to say it when you as the patient walk in, or as we as the provider walk in to talk to you.
Okay. Yes, you.
Especially with seniors, Ryan. My husband and I have a non-medical in-home care business. And we're not unique in the sense that what we're supposed to do is to make life easier for people who need our services periodically. I'll give you an example of what the problem is. I went out to see a couple, one of the two women, one of the women just gotten out of the hospital and needed our care for a finite period of time. Now, they didn't know I was gay. I knew they were lesbian. Okay. And I didn't say anything because I wanted to know what the reaction was going to be. And the language they used and the posture that they had didn't identify those two as loving individuals until I said, hey, I'm family. And then it changed. It changed dramatically. And the care that we were able to provide was more open and understanding. But there has to be some way in this field, because it's growing, to get that point across to those people.
Absolutely. Absolutely correct.
He has a question. He's been having his hand up.
Oh, it's okay. I'm not hurt. You may not come up to say what I'm going to say.
Right.
My husband and I not just received our own Medicare, and we have a supplement. I was really surprised when I called almost all day doctors in Dallas. No one would take a new patient that is on Medicare. I finally found one doctor.
Yep.
Why?
Because they don't pay you enough money. You can't
Well,
survive.
you have to get service somewhere. I mean, money has to be, of course, everyone wants to make money, but I
We
just
have to
don't
see,
understand it.
I have to see 30 patients a day, 15 minutes apiece. I'm sorry, that's just the way it is. And I make half as much money as I made seeing 12 patients a day in 1983. So that's why we don't go to the hospital anymore. We can't go to the hospital and see when you need your doctor the most. You want him to be at your side in the hospital, right? It takes an hour and a half to get to Baylor and back. I can see 12 patients in that period of time. So it's a matter of, you're already in primary care. You don't get paid enough. Now, Obama's has tried to build some incentives for primary care medicine, but we can't survive. If we saw 5 Medicare patients a day out of that 25 that pays us $70 a visit, there's no way we can survive.
So the bottom line is, Medicare doesn't pay you all that money.
Correct.
And
So
when
we
I
suffer.
see Medicare patients.
So we suffer.
But I think the big question is there are too few providers for us. Too few providers that are aware of the specific problems related to the aging LGBT. And the providers that are there, we do not know how to contact them.
Right.
So one of the things that we're trying to accomplish with this summit, as well as with the Coalition for Aging, is putting together an information packet or information
The handbook.
resource, putting together a resource so that those of us who need this information can go to a particular place, like the 211 service, and say, I'm gay, I'm looking for a physician, I just moved to this area, or I just became eligible for Medicare, or my partner died and handled all of our affairs, and I don't know what to do. So, you're familiar with the 211 service? Right?
Is it dialing? I'm on,
It's down to the triple.
I'm on the committee for the 211 booklet, and there aren't any listings of, I'll say, separate positions for the
We
LGBT
need to work with the medical
community.
society on that, Brady.
You need to get with me
We need to
because
work
we are
with the medical society
revamping
on
the
that.
book
Because
itself.
all they
So
give you is
there
3
needs to
names,
be-
but they could give you 3 names that were appropriate
I'm
if you
sorry,
identify.
real quick, I just want to address that question. So with the Social Services Committee of the Coalition for Aging LGBT, we have identified 10 organizations in which we are working with within the LGBT community to try to get them added to the source book and added to the website. So we have, matter of fact, we have a meeting next week with Ms. Jacqueline West, who is the she's the interim director over there. And so just know that it is in the works. But we're taking all information that needs to be included. And if you know of doctors who specifically say, hey, I want to work with the gay population and I'm willing to accept Medicare, Medicaid, send them my way, please. Thank
The
you.
Gay and Lesbian Medical Association has a website where you can put in your zip code, and it will show you the providers, the LGBT providers that are within, you pick a radius.
What's the website again?
And,
glma.org.
Yeah.
The question is, the
Yeah,
challenge
Gay
is
Lesbian
how many
Medical
accept
Association.
Medicare?
Huh?
How many of them accept Medicare?
Well, that's what I'm saying. When you pull up that list, you can ring them and say, hey, do you accept Medicare? Some of them even say it on.
Not all the gay physicians are in GLAMA, though. I mean,
Right.
But that's not just an LGBT.
Oh, that's
issue.
correct.
I mean,
It's
there
across the
are a
board.
lot
Yeah.
of internists, a lot of primaries everywhere that don't take Medicare anymore.
Yeah.
Oh, yeah.
Reimbursement is so poor.
So my
It is
question
a
on that is,
universal issue.
Dr. Allen, just a quick question. In your practice, so if your patients are not on Medicare right now, but then they become eligible, they age into the system, do you let them stay?
Yes.
Through this? So
yeah,
you're-
any
you're
patient that
existing
gets
patients-
Medicare within our own practice is obviously
Yeah,
not
let me
wanting
correct
to turn them
myself. I
away.
was told that also.
What?
If they're already on Medicare, or not on Medicare, but most of the doctors out there would continue.
Yeah.
Yeah.
So the recommendation is basically if you have your own doctor right now, stay with them until.
Stay with them.
Until dot, dot, dot.
Find the one you want before you go on Medicare.
One more question.
I have a question for the panel. Is this okay?
Oh, absolutely.
So you all mentioned in some form about, like you wrote, do you know what your medical issues are? And you all mentioned about self-identifying to your physician, okay? But you make it sound so easy. Just self-identify, just self-identify. Okay, so for many people who have trouble with that because their doctor or nurse practitioner, whomever they're seeing, is not giving them a welcoming sensation. So you pull back. You're tentative about self-identifying. I don't care what age you are, if you're 30, or even so, if you're 60. You're out to your friends, you're out to your private life, but you're not necessarily out to your physician or nurse practitioner. So my question is, what advice do you have for people to try to help them through that?
Well, our goal isn't to make you come out to your provider. It would be nice, but we're not going to say you must do this to get good care. It's helpful to get the best care, but I recognize that there's a lot of different situations. Some people are out, some people are not, some people are in between. The problem with that is that if you are relying on the provider to give you what your health concerns should be and address those, that becomes an issue, because if they don't know that you're LGBT, they're not going to address those issues, even if they know what they are. Which is why I say, do you know what they are? So, for example, lesbians with breast health. Right? Do you know that you need to get mammograms? Do you know that you need to have certain tests done? If you aren't aware that you need to get it done, then you can't go in and ask for it. And a lot of providers are pretty open to, hey, is it time for my mammogram? Is it time for my pap smear? They're pretty open to providing the service. If you don't tell them, hey, I need this service, they won't be able to tell you. Regardless of whether you're out to them or not, knowing what services you need really goes a long way towards making sure that you keep yourself healthy.
Okay, well, you know what your service, you know what you need, but how do you, I'm just asking you, how would you guide an individual to help them to feel more comfortable?
Well, I think part of it is my responsibility to ask, you sleep with men, women, or both? You know, something non-judgmental. I mean, I'm going to take a sexual history, but I can just tell you, a lot of doctors don't do that. And I think we're so used to it with the AIDS epidemic. You know, I ask gay men what they do in bed, not who they sleep with, men, women, or both, but exactly tell me what your sexual practices are, because I need to know that to do you a good job in your sexual health. So it is my responsibility to guide you through that, but I can tell you a vast majority of physicians, especially older physicians, they defer it, or they don't do it, or they don't have time for it, you know.
And it's for that reason that we're teaching the younger generation, when I said those panels and these courses that we're teaching them to do that. We're getting them used to the fact that they need to do that, because otherwise they can't take a good history. They can't take the most complete history to give you the best care. So it's going to take time to fix that, and you know, that's unfortunate, but it is at least in the works for being fixed by starting the younger generation off with, hey, this is how I have to take this sexual history, and we run them through a series of simulations where they have to actually physically do it, and then they become used to it.
Excuse me, so, just 1 second. Okay, we understand we're at the point where we know that we have to do certain things, but then we come back to the practitioners, the doctors, the nurses, the ones that are not gay, the ones that don't know what we need. How can we do something about that?
You know, I started with the Texas Nurses Association District 4, which encompasses, you know, primarily Dallas County, and I did a small continuing ed program for them back in May. There needs to be a lot more of that done, and, you know, organizations only meet so often, and they have other business and whatnot, so it's going to be, you know, chipping at a big old block. But, you know, professionally, I think, you know, our goal is to get out there and through Educare and the coalition and be able to help to do this kind of education and advocacy. And like I said, you pressuring healthcare systems, the Presbyterian, the private entities, the tenants and whatnot, pressuring those systems to get more LGBT oriented is going to get their practitioners and associates more knowledgeable as well, and they'll offer more in-house programs and stuff. There's going to be one at Presbyterian on Tuesday, and so as we start to chip away at this block, all of us in our multi-tiered, you know, professional areas and stuff, that's going to help too. So if there are some of y'all out here, or you know other healthcare professionals who are willing and want to help do some of this education, come forward, please.
Let's take the issue of PrEP, pre-exposure prophylaxis for HIV, right? You go to your doctor and say, Doctor so-and-so, I want to be on PrEP, and he goes, well, I don't do that. And you go, yes, you do. You do need to learn it, because we cannot all do. I mean, African American community, how many African American doctors prescribe PrEP? Not very, that aren't HIV. How many have the discussion about PrEP or think you're at risk as an African American woman? And in young, how do you get to the young adolescent population about PrEP? The HIV doctors can't do all the PrEP. We're taking care of all the patients. Now, granted, they're mostly well, but so I think you have to say, no, I need you to be my doctor, and I need you to find out about PrEP. It's one pill. It's like prescribing metformin. It's not chemotherapy. You got to fill out a form. You got to check an HIV test. You got a hepatitis B test, and you see me every 3 months and do an HIV test and a blood test. I mean, how difficult is that? It's routine. So some of that has to come from you, if you have a provider you like, to help educate them about something very simple.
So the key to everything sounds like it's education. So now you mentioned Educare. What is, for those of the audience that are not familiar with Educare, what is that?
Educare is a nonprofit organization, and the board chair and the CEO president are sitting right here. We started about 4 years ago, and we're growing. And the whole idea is to provide caregiver education, healthcare provider education on LGBT, aging, healthcare issues, and also compassion fatigue. We haven't talked about that except you alluded to it in the other conference. When you're a caregiver for your family member, your partner, your spouse, whoever, and that the stress that comes from that is huge. And Educare has an annual program on compassion fatigue. It's very low cost, and it gives people a chance to be able to learn more about what is compassion fatigue and the science of it, and then also to learn a lot of alternative ways to be able to help to manage your health. Because a lot of times, you know, caregiving can be a long road. And what happens is, you know, caregivers die sometimes before the patient does. And so we don't want that. And, you know, we need the caregivers to stay healthy and to stay invigorated and involved and to have something in their life that helps them. And so coming to that, it happens in the spring, generally kind of March, April, and it'll be on our website as well. And the other, we start with awareness in Educare. You know, if healthcare providers are not aware, they're certainly not going to go the extra step to get educated. And so Educare's awareness programs happen on a quarterly basis with a light dinner, the movie Gen Silent, which was shown at Gala, earlier last month, I guess it was. And that's a really good film to help introduce people to some of the concepts and issues that older LGBT people can have in aging. And it's a way to begin the conversation and to get them more involved so that hopefully then they can bring us into their organizations to be able to do further education.
These are in the packet.
Yeah, and they're in the packet. So any of you all are welcome, or refer somebody you think needs to come to the August 9th program. They're held at the Senior Source down on Harry Hines in Dallas.
Now,
Thank you.
Yeah, just to fall back up on Dr. Allen, you're saying so I've seen it over 20 years. When you first go to the doctor, you'd had like a longer time to interact with your doctor, and now it's less time. There's maybe the nurses and things, and doctors come in. Now it's, like you said, it's 15 minutes or less. What are the things that we can do as patients and spread to other people, let them know, okay, proactively before we get to our visit, how to set up in a way that becomes the most bang for the buck, dynamic interaction that you would want to have in your most ideal patient. And as patients, we will have the most ideal payoff, or, you know.
Well, you know, that varies so much from patient to patient, and how long you've known the patient. But if someone would come in with a succinct list and just read it off to me, would be a good way to start, rather than, you know, talking for 10 minutes and not, you know, but it's a partnership too. And so I need to listen to your concerns, but I think if you came in with a succinct list of what your goals are for this visit, I need my blood pressure checked, that's it, rather than, you know, another, you know, something that may not need to be addressed at this visit.
So would you say would there be other ways that we could get those things engaged with you without actually having to do the visits, so that?
Well, you can send me an email in our practice, and so I know what you want to talk about in your visit, and then I'll put it in your chart.
Do you think there's maybe within the group here, or coalitions and whatnot, ways of getting that information out to, say, hear more ideal ways of getting health care, covering some of the needs without actually having to do patient visits, because this is becoming the trend, right? Where
Well, telemedicine is not legal in Texas. Part of the problem, I could do a lot of what I do on the phone, or we don't get paid for it, for one. But I think, yes, we need new innovative strategies like that, because I can handle most of the things over the phone with you without touching you, although I like to touch patients, and you know, I think it's important for the dynamic of doctor-patient relationships, but I don't think that's necessary for the vast majority of primary care things that we do. You can check your blood pressures at home, right, and send them to me, and then I can change your meds, you don't have to see me. I believe these blood pressure machines are accurate for the most part. I've checked your machine against mine, and it's accurate. So I think there are innovative strategies that would help, decrease
Bring
things.
stuff
You
to
can,
you.
because I think you do less.
Let me interrupt you for a minute. You should have some cards or index cards. If you have questions or you have comments, something that you would like to pass along to our panelists, or something that you think that the Coalition for Aging should address, please write those down.
I think that's a good.
Okay, and we want to try and cover as much territory as we can in the time that we can.
What I heard you say was you want the coalition to come up with like a top 10 list of what you should ask your doctor or,
hell yeah,
or
that's out
what
there.
you should
Yeah.
raise
That's
with your
out there
doctor
on
when you go
NIH,
for your
that's
appointment.
out there on
Is
NIH
that right?
stuff,
That makes sense.
on the websites, how to
Okay.
visit your doctor.
Yes, sir.
Before you do, though, I want to say one quick thing. I think it's also important that patients, generally speaking, understand what happens in the medical appointment. Because when you come in to see your provider, if you're uncomfortable with something and you decide, oh, I just need to keep talking about this, and then I bring it up at the very end, if bringing it up at the very end gives us almost no time at all to deal with it. And when you're looking at what you're going to be doing with your time, with your provider, keep in mind that the more time that you're spending not doing the thing that you want to do, that's exactly as much time as we're going to spend not doing it because we don't know you need it done.
Well, and the other thing is how many of y'all are tired of waiting in the waiting room?
Yep.
Okay, you know why you're waiting there is because somebody popped something that was really serious at the end of their appointment.
By the way.
I love my gay doctor. I worked hard to get him.
Yay.
The big issue for me as a future senior seeker of medical stuff is that I have that relationship. It's really good, and I need to know, like you said earlier, people aren't going into general practice as gay doctors and out there, partially because AIDS is sort of the bell curves down. I'd like to see in the future discussion and attention on, people, doctors being out and visible, and so that relationship, because, patients, you have a special relationship with your doctor, and it's huge and comforting, and we want that to continue, so that being out, and why don't people go into, instead of specialties?
Well, one of the things is that a lot of the care that people get could be provided by nurse practitioners and physician assistants as a first line thing. And then let the doctors who have already, spent time and energy specializing, let them do the specialty work. And then that way, that would give us an expanded amount of healthcare providers.
We have 3 minutes, and I have one last question that I'd like to address to our panel. There's a couple right here. Now, just suppose that one of them became incapacitated for some reason. What advice would you give them now about things they need to address to make sure that their wishes are carried forth?
Power of attorney, will, medical will. Yep.
Disposition of remains, even.
I'm sorry.
Disposition remains follows those. Yeah.
There are 6 documents that, whether you're gay or straight, that you
direct
need.
To a physician if you're married.
I'm sorry, say that again?
You need, everybody needs one.
Fortunately, we've been together 40 years. We had this a long time ago, directed to the physician. So if we're traveling or whatever. Now that we're married, do we still need, does that make sense?
To carry that with us?
Yes.
Do we still need
I
it?
Just to be safe.
Yeah, I
We're
would.
married.
Yeah, you need to attend the legal seminar.
And your doctor should have a copy in the
Oh,
chart.
we do that.
hopefully.
Yeah, we got all that.
Congratulations, by the way.
Yeah.
Can I just say one thing? There are LGBT, elder care attorneys in our city. So I would suggest, there are elder care attorneys in the city. Lori Lou is one, we've got another one that's a sponsor here. I would suggest contacting an attorney, putting all your papers in order.
Yeah, it is
Okay,
worth
so
talking to an attorney for that
let's-
because you don't want to.
I'm sorry, we have to wrap this up. We have 1 minute. So I'd just like to say our next session starts at 12:40 in room 122. This room is going to be legislative, and room 100 is going to be social. If you would like to come back to the caregiving session, we're going to be in room 102, and housing is in 114. I would like to thank our panelists. You've been great. Thank our sponsors, and thank you guys very much.